All right, welcome back everyone to another virtual shouting session at Hearts for Health. We're glad you can join us this Monday evening. I hope your summer is going well. We're now almost halfway through June, so it's passing by pretty quick. But today's session will be with Dr. Anani. He's an emergency physician who works as medical director and also chief of staff at Northcrest Emergency Department in Nashville, Tennessee. I have a few quick reminders, though, before we hop on to Dr. Anani's presentation, especially if you're new to our virtual shouting program. These are going to be really helpful just for you to know your way around how we work. For this program in specific, we do have a few others outside of this. But in terms of our structure, we do have a Q&A at the end. So if you have any questions for Dr. Anani, please do feel free to type them in the chat. He has a few questions as we go through the presentation too. So please feel free to type in your answers along with that. And then another thing is, this is the last reminder, if you'd like to hear more about our virtual shouting sessions, because we do have them on Mondays and Thursdays on a consistent basis every week through this semester, through the whole summer. So to hear about them, we have flyers posted on our Instagram page, and we also have them over our email listserv. Our email listserv does have a little more information about our other programs, and those other programs have to do with mentorship, have to do with volunteering. If you happen to be interested in that, I do recommend our email listserv, but we also do post those type of opportunities over Instagram. It's just a little less frequent. And in terms of joining our email listserv, you can do that by subscribing on our website. At the very bottom, there's a subscription form. Just type in your name, your email, and click submit. You'll be good to go. Or you can just email us and we can manually add you on. Our email is community@hearts4health.org. And like I said, we can add you on from there. Any questions can also be directed over there, whether it's about today's session, about the quiz that we have, and I'll talk a little more about the quiz at the very end. But any questions, we're happy to take over email. With that said, though, I don't want to take up too much time. So Dr. Anani, feel free to take it away.
Thank you very much for that, Michael. I really appreciate that. And just because you're the only one I can see live right now, if you can hear me, just put a thumbs up. All right, we are good to go. Thank you all for joining. My name is Dr. Anani. I do work at Torpor University, hence the polo and the background. I also work with the Student National Medical Association. I'm the professional board member to the EC this year, so hoping for a very good year. The only thing I will state is if you hear any loud noises in the background, I am going to explain why in the next slide, but don't worry, I'm not in trouble. Also, this is going to be as best as possible an interactive chat and an interactive session, right? When you shadow in the ED, you get asked questions. So I will be asking some questions. They're not going to be that hard. Most of the time, I just want opinions. So right now, feel free if you're watching, if you're able, I do have the live chat up. You can go ahead and just put what state you're from. I don't even need your name, just whatever state you're in right now. If you could throw that in the chat, I'm going to be going back and forth and looking at the screen so I can tell how much of a delay I have so I know how early to give you guys questions. All right, let's move forward a little bit to our agenda. I'm going to give you guys a little bit of background about myself. I know some people here may know who I am, but most probably don't. Then we're going to talk about the road to emergency medicine. We're going to go through 3 real cases. My personal thought that I often give while on shift, and then I'll close with some Q&A. Again, using the chat. I see there's an Arizona out there, and I see there's a Texas and Oklahoma, so that's very good. So using the chat, things should look pretty good. Just continue to post and continue to ask questions, and we're going to roll through this together. Lots of Texas. I'm from Houston, Texas. There's Oklahoma out there, California, North Carolina. Very excited. So some speaker background. As stated, I technically get a paycheck from American Physician Partners. That is the group that staffs the hospital I work at. And with that group, I am currently the medical director at that site, TriStar Northcrest Medical Center. Again, that's where I work. That's where I drive to every single day. It's a very fun place and a place that I've enjoyed working at since 2015. I'm also the Robertson County EMS medical director. That means I work and do the protocols for all of the EMS workers, the paramedics. Basically, if you don't know, when a paramedic pulls up to your house and they give you a medication, a physician has to basically order that medication. So I have a standard of protocols that says what they can and can't give based on that situation. I am board certified in emergency medicine. That is what I do on a daily basis. My favorite pastime is video games. I enjoy them a lot. The PS5 is what my wife jokingly calls the second mistress. Actually, it's the first mistress. She just calls it mistress in general. But it's where I spend most of my time. Currently, just downloaded Diablo 4. Destiny tends to be my main game. And then in the background, I like things like God of War and things like that. You can also put those in the chat. I will answer any questions about video games because that's what I love as well. I am married, as stated, to my high school sweetheart, our med school sweetheart, Dr. Uchenna Anani. We met at Howard University College of Medicine, and we did do the couples match. She works at Vanderbilt University in neonatology. She is obviously, and as she should be, the brains of the family, makes the family go. I tell everyone she's the important one, and I'm just a tall guy behind her. We have two little bosses, and this may be the loud noises you hear in the background. Joseph is in the Iron Man shirt with the green cup, and Jacob is in the Hulk shirt with the purple cup. They basically run our entire house now. We have no say in what we do and what we eat and what time we wake up and or go to sleep. But you know, that's what happens when you have two toddlers. They are 2.5, and they will be 3 this September. All right. So for those who don't know, this is the road to how you get to be an emergency medicine physician from undergrad. So undergraduate time is 2 to 4 years. I put 2 to 4 years because most people should know by now that you actually don't have to graduate college to go to med school. You just have to do the prerequisites for medical school and do very well on the MCAT. Most people need all 4 years to do the prerequisites, but if for some reason you hate sleep and are addicted to caffeine, you may be able to do that in 2 years. Underneath, I did put gap years. So it's 2 to 4 undergraduate years, just about. But some people do gap years. I did one. I took a year off after undergrad, studied for the MCAT for about 2-3 months, and then I finally went in and took the test. Medical school is about 4 years. Again, some people have some bumps on the roads, or for some reason you can shorten it. It's about 4 years. You apply for what's known as the match during your 4th year. The match is basically the draft for medical specialties. You rank where you want to go based on places you got interviews at. They rank you, and then a supercomputer matches you guys and says, hey, you rank this program 1. They ranked you number 30. Y'all match there because the other 28 people either went somewhere else or are part of the program. It's a very interesting process. You can see it every March. Take over Twitter, just known as the match. I definitely tell people to look into it. So I matched into emergency medicine. Most ER programs are 3 to 4 years. Mine was 3 years. You can have 4-year programs. They tend to have some extra specialty and extra leadership time behind it. Then you become an attending, like I am. And you get to do that forever. No more studying all the time. You do need to study because medicine is a lifelong learning thing, but you're not glued to a book. You get attending pay and you get a lot more freedom. All right, my personal journey to emergency medicine. I went to Kerr High School, again, in Houston, Texas, Alief, Southwest. Then I went to Carleton College, 2007. Again, took a gap year in Houston from 07 to 08. Howard University College of Medicine, 2012. And then Central Michigan University, which I abbreviated CMU, where I finished residency in 2015. I was chief resident from 2014 to 2015. I'm going to move this down in case it's blocking. But these are a group of my friends from Carleton College in 07. Yes, things were a lot baggier back then. But this is me here. I'm a physician. This is my friend Maya Warren. She has a PhD in food science and actually won the Amazing Race. My friend Sadrina, she has a PhD in psychology. My friend Jessica, she has an MBA. And my 4-year roommate, William, who has a PharmD. So you know, birds of a feather flock together. You don't have to have all med school friends. You just have friends that push you and you push them. All right. So before we get started, to everyone out there, I'm assuming you want to go into medicine. Every journey begins with 1 step. That's a quote from Maya Angelou. Just hold it together, hold it in your heart. Yes, you're gonna have to take some tests. Yes, you're gonna have to do some things. Yes, you may have to shadow in person nowadays. But as long as you know that every journey begins with 1 step, you just take that step forward. 1 foot in front of the other. As you know, the old saying goes, just keep swimming, just keep swimming. Same thing here. Just keep walking, just keep moving towards your goal, and boom, you can end up in medicine. So we are now into our cases. I will read them out loud. I'm going to preface right now, if you are in the chat as I am talking, feel free to post what you think this patient may be having as a medical diagnosis or is going on. If you have any questions that you want me to elaborate on, put them in the chat. Again, I'm looking at it in live time, so I can go back and say, all right, you wanted to know this more about the patient. We can go from there. So case 1, the patient is Pop Pop, as we will call him. Pop is an 83-year-old male, self-identified, who has a chief complaint of chest pain. He's not really talking very much when he comes into the emergency department, so his daughter is telling most of the history of present illness, HPI. Daughter states that Pop woke up his daughter suddenly at 12:30 a.m. and said his chest was hurting. Pop told his daughter it was severe and crushing. Pop has never had pain like this before, and now he is sweating. All right, everyone's thinking about what's going on in the case. You start typing some things out. We're going to walk in the room and ask Pop some questions. So our review of systems, where we go over everything. We ask Pop, how are you feeling? He says, I'm having chest pain. We ask Pop, are you feeling short of breath? He says, a little bit. We ask Pop where he's hurting. He points to kind of the center of his chest. We ask Pop to describe the pain. He rates it at about 8 or 9 out of 10, but he looks very, very uncomfortable. We ask him if he has any abdominal pain. He says, no, it's all in his chest. It's all in his chest. Please make it stop. Yeah, he states that he's a little nauseous, but has not vomited, and he denies any difficulty going to the bathroom or any stomach pain. If you have any further questions for Pop, again, please put them in the chat, and I will go back and answer them, and we'll go back and ask them, and then I'll answer them as Pop. So on physical exam, we walk in and see that there's an elderly male. He looks well-nourished. He's eating, but he looks a little uncomfortable. There's some buzzing that's noted in the room. We can't quite figure out what that is. We look at Pop's mouth. He has mucous membranes, or like his oral pharynx. It's pretty moist. It looks okay. He has spit. He has saliva. It does not look dehydrated. We listen to his heart. He has a normal rate and a rhythm. That means his heart is kind of going straight down and straight and narrow. Normal sounds. There's no rubs. There's no rails. There's no abnormal clicking going on. We listen to his lungs. His breath sounds are normal. His abdomen is soft. It's not tender. We look at his extremities. There's no deformities. They're all straight. We look at his skin color. It is normal, but it definitely feels a little clammy. He feels diaphoretic. We take some vital signs. His blood pressure is about 180 over 109. It's a little on the high side, I think. Heart rate is 68, a little on the slow side. He's breathing about 16 times a minute with his oxygen saturation about 94% en room air. We take his temperature, it's 97.9 degrees Fahrenheit. That's about it. So differentials. These are things in medicine that we say what we think is going on. In emergency medicine, every time you see a patient and you walk away, you need to have a list of differentials in your head, right? Patients don't tell you exactly what's going on. They may Google it before they come in, but that doesn't necessarily say what is actually going on. You have to make that decision. So right now, if we were in person and you were shadowing me, I'd say, give me your differentials. Again, you can write them in the chat if you want to play along about what you think is happening. But I will go with what differentials I standardly have for an elderly gentleman with chest pain. So what is going on? Again, this is your time in the chat to add in. This is your last flare. And then we'll move to some differentials. So my differentials tend to be for an elderly gentleman with chest pain. Number one, myocardial infarction, or an MI, which is a big fancy word for the heart attack. So is he having a heart attack? Number two, is pulmonary embolism, or a blood clot to the lungs. Do I think there is something blocking the flow of blood through his lungs, preventing oxygen getting to his body, causing some pain? Pneumonia. I know people may be saying they're like, wait, pneumonia, why would he be looking like this? Pneumonia can cause chest pain as it causes inflammation of the chest wall. Pneumonia can also cause some sweating if your temperature is up, even though Pop's is normal. Maybe it's still on the rise. It's not my number one differential. It's not the tippy top, but we put it on there just to remind ourselves to look for it. And of course, the last one is rib fractures. Pop is an elderly gentleman. For all we know, he tripped, fell in the shower, hit his side of getting out of bed, just didn't tell his daughter. Now he's having really bad chest pain. Thought it was just a bruise and he can walk it off, and now he's hurting really badly. So broken bones, rib fractures, that can be in our differentials as well. So what we should do next. Pop is an elderly gentleman with chest pain. You always want to get an EKG or ECG, because it is electrocardiogram with the C, of the heart. That's where you get to see the electrical pulses go throughout the heart. It prints out on a piece of paper, and then you can kind of interpret what is going on. You always want to order the labs. That's how you can see if the white blood cell or infection fighting cells are high. Is he anemic? Is there electrolyte difficulty? Is the troponin elevated? That would also be something that you'd have to look into to make sure and confirm things like heart attack, broken ribs, or pneumonia. And of course, for the things I just mentioned, an X-ray is excellent. Even in a heart attack, sometimes it's not a heart attack, it's heart failure, and you can see fluid on a chest X-ray. You can see the heart looking very, very big. So it's always important to get an X-ray as well. So we went and did those things in the order that we got them. And this is the EKG or ECG that came up for pop. Now, I've been checking the chat and no one was worried about this, or no one typed that they were worried about this, but this is the EKG that we'd be getting. Most of you out there probably don't know how to read an EKG, and that's understandable. If you do know what this is, you can put it in the chat. And if you don't know what this is, here are some arrows for what you should be paying attention to. All right. Looking at all these segments, looking at all these electrical things. For anyone who's seen kind of a picture of an EKG, this looks kind of normalish over here, the up and down. This looks kind of normalish down here. This does not look normal. That does not look normal. And that looks just downright scary. Everything is really high up in the air. We call that ST elevation because this is the PQRS segment down here, and this is the T over there. So this is the ST segment, this space to this space, and it's now elevated. So we call that ST segment elevation, which is very, very concerning for what our diagnosis is. ST segment elevation myocardial infarction, or STEMI, as we call it. One of our few nicknames in emergency medicine. But the MI, as I stated on the slide earlier, is short for a heart attack. So this patient is having a specific type of heart attack where the ST segment is elevated. This is very concerning for an acute, meaning very recent occlusion, and a rather large one as well. The one good thing about these occlusions are we can go in medically and open them up. Not me, but cardiologists can, and people in the cardiology space. They can go in, solve these heart attacks right then and there, and save a lot of the heart. But if you're getting these, a little part of the heart's already starting to die. So next steps, we need to immediately notify our team of our diagnosis. When you work in the ER, you do not work alone. You're gonna have nurses, you're gonna have techs, there's gonna be a PA somewhere, maybe a nurse practitioner, but you're gonna have people around you. If you keep this diagnosis to yourself, no one's gonna know how critical the patient is. So you need to update that patient's nurse, the charge nurse, and everyone that needs to be involved immediately. Hey, we have a STEMI in room whatever, pop needs to be stabilized. The second thing you need to do is make sure you talk to the family if they're there. If they are there, you need to update them because, again, there are interventions that can be done for a heart attack. But what if the patient or the patient's family doesn't want those interventions? They do not resuscitate, or they do not stay in the hospital, or they're on hospice. Those are the things that you have to discuss with them early. Now, if they're all a go and they say, we want to save Pop's life no matter what, then you notify your cardiologist of your diagnosis, whether your cardiologist is local or somewhere nearby, and you make sure that you get Pop to them ASAP. Always circle back around and review your orders and things that you put in based on your differentials. You get to see what needs to be corrected. Sometimes the potassium is too high. Sometimes the potassium is too low in these cases. Make sure you want to go back and fix those. And then last but not least, you want to get the patient to the cath lab ASAP. The cath lab is the place where they go in and open up those vessels. So the blood flow that's being blocked can now be opened thanks to the cardiologist and their team. Sometimes they can, if you ever hear someone say, I have a stent in my heart, that's what they got done. When someone gets open heart surgery or a bypass, that means that portion of the heart could not fit a stent, or it was too hard to get a stent through. So they had to bypass all the way around that area of blockage. And some things you want to do in the ER, even though the cath lab is doing all the work, again, get them pain medication, blood thinners to make sure whatever that clot is, whatever that blockage is not getting bigger. Sometimes the platelets can go and sit on that in that area. You don't want it to get bigger at all. Oxygen, if they need it, it's not mandatory to be mandatory, but the one thing we learned, it doesn't hurt in the short term. The patient may feel short of breath. Oxygen may help open some things up. And then you can put anything else you need or order anything else you need to make them feel better. Nitroglycerin, Lasix, things of that nature. So hopefully everyone's feeling a little, relaxed, calm. We're going to go on to our second case. Again, feel free as we go through this one to put in the chat what you think is going on. It's going to be very similar to Pop-Pop's case, but a little bit different. So hopefully you can catch that on. Case number 2, this patient is Drizzy. Drizzy is a 34-year-old male as identified who came in with chest pain. HPI is given by Drizzy. He was watching TV, started to have some pain in the center of his chest. He states it started to increase and then it radiated to his left arm. The pain went from a 3 to a 6, so he came in for evaluation because he heard this could be bad. He heard this could not be good. He could be having all types of things going wrong with him. He wanted to make sure he was fine. So review systems. That's again where we ask the patient questions. What's wrong with you? How are you feeling? How long has this been going on? And then you ask for each system, head, eyes, nose, mouth, lungs, heart, stomach, bones. You ask one by one what could be going on. So we went and asked Drizzy lots of questions. The only place you said he was hurting in his chest and it was radiating to his left arm. He didn't feel that short of breath. He didn't feel any fever. It started suddenly. He just wanted it checked out. No stomach pain. Nothing else was going on. If you have any questions for Drizzy, make sure you can drop them in the chat as well. I'll answer them on stream if you have any. So physical exam for Drizzy. He is a middle-aged male, appears well-nourished, well-appearing. No, he's not disheveled. He looks well put together. He, too, has moist mucous membranes, meaning he doesn't look dehydrated at all. You listen to his heart sounds, normal rate and rhythm, normal sounds. Listen to his lungs, everything sounds normal. Press on his abdomen, soft, non-tender, that's normal. Extremities, no deformities, that's pretty normal. You look at his skin, normal color, dry skin, no bad sweat. He's just in bed asking you to figure out what's going on with him. Here are his vital signs. Blood pressure is 130/79, heart rate's 88, respiratory rate 16, O2 sats 97 on room air, temperature is 98.9. He looks fine. He's feeling okay. All his vital signs, if you don't know vital signs, are very, very stable. So again, I ask you, what is going on here? What are your differentials? What's going on? If anyone has any thoughts, you can chime in, let me know. I obviously have my thoughts because I have to as a physician, but anyone who wants to be a physician should also have some thoughts behind what's going on. So if you think start placing them in the chat. We'll figure it out. We'll go forward from there, but what's going on with Drizzy? And no, this is not Drizzy from Canada. It's fake Drizzy. So moving forward, we should list our differentials again. They should be very, very similar to Pop-Pop, but a little bit different. In the ER, someone says chest pain, it's a heart attack until proven otherwise. First thing you want to take off the table is a heart attack. Every single time, do not delay. You have to do what you have to do. Pulmonary embolism is still up there. Again, a young person can't get a blood clot. If they're not moving around very much, they're very stationary, watching a lot of TV or Netflix, the blood clots can form, make their way to the lungs. So that makes a lot of sense. Again, pneumonia and infection in the lungs. Drizzy's young, but maybe he smokes or he does things on the side. This will be a good differential to make sure to rule out because you want to make sure he feels fine. And then last but not least, costochondritis, which is inflammation of the ribs. It's a diagnosis that doesn't have any real test, but it's very common in young people. You can feel kind of an inflammation in your chest wall that's often treated by NSAIDs or steroids. And steroids are non-steroidal medications like Motrin and things like that, pain medicine. So what should we do next based off those differentials? Again, it's going to seem very, very similar to Pop-Pop. You got to rule out a chest. You got to rule out a myocardial infarction first, so you get your EKG. You can get your chest X-ray at the same time. You want to make sure you get labs. Now, the one special thing about Drizzy's case is chest pain, center of his chest goes to the left arm, but it's kind of near the middle as well. So you want to throw on what's known as the lipase, which can measure the values of the pancreas, can tell you if there's any pancreatitis or anything along those lines. Very, very useful tool. But while you're waiting for all the Drizzy stuff to come back, another patient checks in, patient number 3. It's known as Meemaw. Now, I know Pop got you all to himself, but he was having an MI, and he saw it immediately. Drizzy seems a lot more stable, and Meemaw's coming in, and nurses are taking him to the room. But Meemaw is a 78-year-old female whose main complaint is reflux. She says it kind of hurts here and it's going up here. It's her reflux acting up again. She says she has a history of ulcers and also has some ulcer pain. She says that the pain has been bubbling up throughout the day. So it hasn't hit her immediately, but since, let's say, about 7 o'clock this morning until now, it's been increasing. She says she's been burping, taking her medications, but nothing has helped. She takes and reports it's just underneath her breastbone and radiates towards the back at times. She rates the pain as about a 6 out of 10. So a little above normal, but nothing too crazy. On review systems, this is our time again to ask questions based on the differentials that we have. So as you start listing out your differentials in the chat, I'll let you know that we ask your review systems. She reports some abdominal pain going into her stomach. She states that it radiates towards the back. It feels kind of like it's a shaking or on a timer. It's not consistent, but comes and goes. As time progresses, it's been getting a lot harder and a lot more painful. She feels like her stomach is getting a little bit bigger at this time. She does not feel short of breath. She feels maybe a little warm, but nothing too crazy, and otherwise feels stable. On physical exam, we see an elderly appearing female, well nourished, well appearing. She has moist mucous membranes. Again, she does not look dehydrated. You listen to her heart, normal rate and rhythm, normal sounds. Breath sounds feel good. Now, you press around her stomach, it's soft, a little bit tender in the epigastric region. That's the region right up here, just beneath that breastbone area. And periumbilical, as you can assume, around the umbilicus or around the belly button. She has some tenderness as well. Those two areas seem a little surprising, kind of not generally massively far apart, but not as close as we think. We look at her extremities, normal, no deformities. Her skin's pretty dry, which is a good thing, but man, she looks a little pale here. Her vital signs are an elevated blood pressure, 189 over 129. Heart rate is 95, so her heart isn't moving. Respiratory rate is 16. She's saturating 95% on room air, and her temperature is 98 degrees Fahrenheit. So differentials, right? Everyone has to start listing out what the thing is going on. We are working in the ED. We have to work at lightning speed. People check in, they give you a story. You got to try to figure out what's going on before you leave the room, or at least what test you want to order. So wait, what is going on here with Meemaw? Meemaw is definitely different from Drizzy. Still a little similar to Pop, but something just seems off. Still waiting to see if anyone has it. If you can put it in the chat, I'll be very surprised if you know what this is, but we'll move on. So differentials you want to have GERD or acid reflux, right? Hurts near the stomach area, goes into the chest, intermittent, which means it goes up and down, up and down. Sounds kind of like GERD. Pancreatitis is inflammation of the pancreas, which lives again in the epigastric region. When people have it, it radiates towards the back. It can be pretty painful, and eating and drinking is just not fun when you have pancreatitis. Again, it's pretty near to her chest. Meemaw is a little on the older side. You gotta at least think myocardial infarction. It's probably not what's going on because we just saw a case and this does not look similar to that. But you at least want to think, all right, how can I rule this out and or rule this in? Last but not least, any kind of belly problem can be going on, right? Gallbladder, colon issue, trouble going to the restroom, UTIs, any of these things can be on the differential list now because Meemaw has opened Pandora's box, an elderly woman's abdomen. So what we should do next for Meemaw, you want to order some labs, get things cooking. CBC, CMP, complete metabolic panel, lipase, so you can check out the pancreas, and then the UA and coags, just to make sure there's no UTI. So UA is urinalysis, and coags, if there's any kind of surgical thing going on at this age, you're going to make sure that her blood is not too thin. There's nothing going on at that standpoint. You should give her some medications, try to relax her pain, see if her pain relaxes, see the blood pressure will get better as well. And then, of course, order the EKG. So We're back to case 2. You have everything in now we want for case 3. Things are cooking up. We're in the ER. We have to know how to juggle. All back to case 2. This is Drizzy's results. This is his EKG. Nurse brings it to you. You take a look at it. You have to think about what you think about it. So earlier we talked about the ST segment here to there being much more elevated. Don't see that anywhere here. Even if you want to be generous and say, well, there's a little hump right there, it doesn't get off the actual ST segment and go in the air high enough. It has to be at least 1 or 2 blocks above the baseline. And by blocks, I mean these little tiny boop, boop, boop right there. Tiny, tiny boxes. Anyways, looking at this, you can see that you have your P wave right there. Q, R, S, little line to the top of your last hump with your T segment. No elevation there. Things look good. Again, for anyone looking that can follow along my mouse, you have your P wave. Q waves are here. R is up top. S is down here. T. Q, R, S, T. All right. So looking at this, we can unequivocally say that Drizzy's EKG is normal. Nothing really going on here. This is his chest x-ray. For anyone who's never looked at chest x-ray before, you guys want to follow kind of like your ABCs of chest x-ray. Trust me, there are a lot of ABCs in emergency medicine. Airway, which is the trachea here. Is it open, going down both sides? Looks pretty good. Breathing, are the lungs inflated? They look pretty good. You also have B for bones. Are the bones broken? You can look at the rib right here and stretch all the way to the back. I don't see anything broken. Your lung is over this part kind of right here, but you just assume it's pretty hard to fracture way over there. On your left side, nothing looks broken bone-wise coming through here. So you look at your chest x-ray, you have to tell yourself, it looks pretty normal. There's no gremlins running around. There's no giant tumors. You're happy with that. So going on to our third case, we're back to Meemaw. Some of her results are starting to come back now. This is her EKG. Again, ST segment's down. PQRST segment looks okay. Looks just like you see in a textbook in any commercial. I'd call it normal too. So Meemaw doesn't appear to be having a big heart attack as well. Here's her chest x-ray. Man, it's like deja vu, right? They look so similar. That's a lot of part of emergency medicine. You see a lot of chest x-rays, a lot of EKGs. They may look the same, they may feel the same. Make sure you assign them to the right person in your head and make sure you know what's going on with each one. So in this case, we just saw a similar chest x-ray. We look at the airway again. All right, down both ways, looking good. You can do B for bones or B for breathing. All right, bones here, I don't see any obvious fracture. Things look good. I'm okay with this one. Looks very familiar. Drizzy, which you call normal. So this one would be called normal as well. All right, let's back to Drizzy. What are we doing with case number 2? So we get his labs back. CBC, which is his complete metabolic or complete blood count, which is your red blood cells, white blood cells, platelets, everything like that, came back normal. We did a comprehensive metabolic panel trying to make sure his potassium is fine, sodium is fine, everything is fine along those lines. Came back normal. Troponin for his heart, make sure he wasn't having a silent heart attack. Normal. Lipase, the pancreas, making sure what's all going on. Normal. You review his vital signs again, looks pretty good, right? The blood pressure is 133/80, heart rate of 85, respiratory rate of 16, O2 sat 99% on room air, temperature is 98 degrees Fahrenheit. Still holding on. Nurses update you also that he's, quote, resting comfortably. Makes you feel awesome at this standpoint. But before you can make it to Drizzy's room, patient 3 needs you immediately. So you start getting some of the labs back. White blood cell count is elevated. All the other ones seem normal, which is good because sometimes the white blood cell count increases with just stress. I tell people all the time, like, hey, your body may just be in pain, having a stress reaction, maybe viral, maybe you got hit from behind. You can run that any way you like, but it does not always mean infection by itself. Complete metabolic panel, again, there's some slight elevations in the liver enzymes. These are the enzymes that monitor the gallbladder and the liver, AST, ALT, bilirubin. Some slight elevation there, but nothing too crazy. Troponin, again, the heart attack level, normal. And lipase looks normal as well. So we're trying to figure out still what's going on with Meemaw. You repeat some vital signs. She's still hypertensive, even probably worse than before. Heart rate's went up to 115. She's now breathing 20 times a minute. Her O2 stats now dropped to 92%, so she needs a little extra oxygen. And her temperature is still sitting at 98 degrees Fahrenheit. The nurse, though, comes and updates us that the pain in the stomach is getting much worse. She looks a little pale, not short of breath. You just don't know what's going on. You're feeling worse. So this will be an interesting standpoint. Right now, we have two cases before us. We have Drizzy's case. We have Mima's case. We're trying to figure it out. Standing at the fork in the road. Which case should we conclude first? Who should we go and see next and say, hey, this is what we need to do for you. This is what we need to go. This is how we need to do it. Now, obviously, Drizzy and Mima are two different people, but you got to figure out which path to go down. And in emergency medicine, always go with the sicker patient. Drizzy's chilling in bed. He's in no acute distress. Vital signs are stable. You know his answer is probably going to be anxiety or something Fast and Furious related, but otherwise, he's stable. Mima, on the other hand, does not look very stable. She has blood pressure issues. Things are not looking great here. I think we all know where we should go. So we go back into Mima's room, right? Hopefully everyone in the chat's putting Mima. And we need to do a repeat examination. So we see there's a pale, elderly female with now worsening vital signs. Her abdomen is now more tender and distended. Feels like something's nearly growing in it. And family's more concerned. They're saying she's getting a little altered. This is anemia. Something just does not appear right. So you take it on the chin and you do what any good ER doc does. You get a picture of where the patient is still hurting. So with this area, we went with our abdominal CT, and we do that with contrast to make sure we can see anything that light up that looks abnormal. So to send her to CT, she has to leave the department. We're nerve-wracked, we're anxious, but we know our nurses can do a good job. The CT scanner is not very far. We can get over there in just an instant. So while Mima is in the CAT scanner, we're trying to figure out what's going on there. We need to do what every ER doc does. You gotta keep moving patients. So it sounds like it's time for Drizzy to go. Drizzy's time is up. So his diagnosis can be what? We don't know. All right. I know it sounds like a crazy answer to hear from a physician, but we don't know everything and we can't figure out everything. We can have differentials, we can have thoughts, we can have ideas. Some things need special tests, some things need a stress test, some things just don't exist. So as I tell everybody, Kanye shrug. I'm not sure which one it is that's going on right now, but I am sure that you're not going to die. And if you need us, we'll be here for the next 72 hours. So the official diagnosis I had to write down is paperwork would be chest pain of uncertain cause, because we don't know where it's coming from. We double check some risk factors. There's a heart score. You actually look it up on your computer. It's a calculation score that lets you tell the risk of somebody coming into the hospital. And 3 is extremely low. And that's what Drizzy was. He had no red flag. Nothing really was going on. He just felt some chest pain. So disposition. Oh, bye. Thank you, Drizzy. You get to follow up with your primary care doctor or your cardiologist. But at the end of the day, it's time for you to go home. So we let Drizzy go home. We're woo-sawing at this standpoint. If you're having any trouble keeping up, again, please post in the chat. Let me know how you're feeling. Let me know what you're thinking at this standpoint. Meanwhile, returns from CT. We're a little quaky of what's going on. She looks sicker. The CT tech just tells you she didn't like the picture. She didn't know what she saw, but she didn't like the picture. Now you're sitting there and you're getting the dreaded call from the radiologist. Radiologists don't call the ER just to call the ER. They have a picture that looks very bad. Something looks off. They want us to know. This is the picture the radiologist shows us. Now, I know everyone's not very familiar with a CAT scan. Imagine this was someone lying flat on the table and someone dropped a knife and went straight through. You separate, this is what you see on the inside. So you see this view and you note that there is some white stuff in the bowel over here. There's some air right there. And we see a big circle sitting right about here. Now what that circle is, now we're about to figure out. We do see this contrast only down the lining of the circle and not in the middle part. So what is going on here with Nemo? There's your positive arrow sign. Look here. Tell us what's going on. I can tell you right now, danger is going on. If you don't know anything, you can look at that one structure and says it looks mighty large in comparison to everything else. That is part of your aorta. That holds a lot of blood and a lot of time. We do not want that system messed up by any reason. So the official name is an abdominal aortic aneurysm. It's very concerning because it can rupture at any moment. There's poor outcomes with ruptures, and physics actually do matter. I know no one wants to hear that studying for the MCAT, but physics matter. You get this equation right here, and you know that force and acceleration is going to affect the shear force of this AAA, or this abdominal aortic aneurysm. So too much force, we can get a fracture, or not fracture, get separation of the lumen, and everyone just goes down. It's not what we like, but you know, we have to take physics for some reason. So there you go. So as we now know our physical equation for AAAs and how they can go bad, we kind of know how they can go right. We lower someone's blood pressure if we make it so they don't have to go back and forward, and we can make it so their blood pressure gets to a nice tiny parameter. They're very relaxed. They're sitting on the couch chilling. We need to be doing that for this case. So number one, you give pain medications. You don't then drown or snow meatball, but it's a little bit to knock out the pain. Then comes the beta blocker. A beta blocker is a heart medicine that slows down the heart rate and also improves the contractility or the squeezing of the heart. So right now we have a very wide open heart rate, and she looks fine, but as you saw in that ultrasound, a AAA is huge. We do not want that rupturing or going large or getting bigger. So we want to get the beta blocker, slow down our force, slow down our acceleration, slow down the property value. Things look good. So now we go in, we inform the patient and the family. We say, hey, Mimo has a AAA. Something's going on. We need to make sure that she's doing okay. You notify the staff of an emergent diagnosis. It's not as emergent as a STEMI, but in small community hospitals, you want to make sure everyone's aware this lady is sitting here with essentially a ticking time bomb in her stomach. If that AAA ruptured, it'd be very bad, and you do not want to be there for that. Inform patient and family, notify staff of the emergency diagnosis. Again, as stated, now we can work on admission and or transfer depending on what type of hospital you have. You need a vascular surgeon on call to come in and help take care of that, because again, if that goes the wrong way, you're looking at death, unfortunately. So we have the diagnosis, we're feeling good, AAA, we've called our vascular surgeon, we're kicking back, we've given all the medications, but remember, it ain't over till it's over. That's Yogi Berra. That quote can also be taken for all our Miami Heat fans out there for basketball. You guys keep hanging in. I think it's gonna be a tough week. Let's just put it like that. So we go back in, we reevaluate the patient. She's now starting to vomit. She's not feeling good. Her stomach is feeling quite queasy. There's a change of heart rate rhythm. She has a change in color, and now she's visibly breathing a little harder. She's breathing faster than she was when she came in by at least 6 to 8 points. So we went in and gave a bolus of medication all over again. We really want to make sure that she's feeling better. So more pain medicine, more nausea medicine, more medicine to slow down that aorta from getting any bigger. We want it to stay at one size now. And she's in this trauma room. She's in a small room off to the side. She needs to be in a trauma room. Let's get her over to the big room where we can get all of our blood products and multiple nurses to, as I like to say, play with this patient all at one time. We don't want to get in trouble just because we're being too cocky or flying by the seat of our pants. And then last but not least, while she's still awake, definitely ask her, does she want to be intubated? Because if she's breathing this hard, her heart rate's going this fast, it may be better and safer for the body to just kind of take over. That's what can happen a lot of times with intubations. You just go in and you take over. For someone who doesn't know what an intubation is, it's where you get to use all of these fancy tools. These tools are great because it allows us to enter the oral pharynx, go down the trachea, and provide direct oxygen to the lungs. You have your different types of blades. These are Macs. These are Millers. Macs have a little curve to them, so you can go in and lift the palate, and Millers are straight back, so you can push the tongue out of the way. You pick the correct side, you can inflate the balloon. This is known as a bougie. So you can go down just the trachea to Sometimes it can be hard to see it very narrow, and they can put the tube over that into the airway. So all great equipment here. This is not Meemaw, wouldn't break HIPAA. Stole this picture from Google, but it had everything we needed. So I just blocked out this person's face. But here's the respirator or the ventilator being connected to the endotracheal tube, going directly into the mouth there. This is an NG tube sucking out contents. So we're not gonna do that for our Meemaw at our hospital. But right now, we do consider the NG tube because that can empty out the stomach and stop all the vomiting. But taking over ventilating is exactly what we need. So we got our vent managed, blood pressure is improved. We called a helicopter. They've arrived. We've gotten the patient to the right place. We got her to the ICU, where there's a vascular surgeon waiting on her, and take her to surgery. All AAAs rupture or get close to rupturing around 8 millimeters, and Meemaw was sitting at nice 6.5. So we had to get her over there as soon as possible. So if you're like me, once the helicopter takes off, I always lean back, do a nice exhale. I like to woo-saw. We had a very busy day. We saw a STEMI. We saw just regular chest pain, which you'll see a lot of, but we saw a AAA and someone presented with just some nausea and vomiting, thought they were dehydrated, thought they felt a little bad. This is a whole lot different. So exhale, feel good about yourself. Finally, I just want to give people some thoughts about how I practice, where I practice, and I get this a lot working for Towards Diversity. I get this a lot while shadowing. Sometimes I wonder if it's just, talking points that people want to make, or if they truly have these questions. So if anyone out there has some of these questions, I'll share my thoughts now. 1, yes, as a Black male physician, I can get racist comments while on shift. It's best to shrug it off or try to go through as best as possible. Make sure you're aware you're taking care of the patient. But 9 times out of 10, it's nothing overt, nothing crazy. That 1 out of 10 times, though, can be a little jarring. So just know that it can exist out there, and it's not just nothing. My thoughts about diversity, especially with the Supreme Court looming down a lot of schools' necks about whether they can do affirmative action or not, is all the studies we have, not thoughts, studies that we have, say that people do better when they have multiple options of physicians. People in inner cities do better when they have physicians from the inner cities, and that having a diverse population gets a diverse frame of thought, right? If everyone thinks the same way and acts the same way, things will be pretty boring. At least TV will, for a matter of fact. And mentorship is necessary. Everyone should find themselves a mentor, someone who can at least guide you down the path of what's already been done. You don't want to have to make up things all over again. So if you know someone who's a physician, just ask them, hey, can I bum a couple of questions off of you? Or if you need to just shadow, kind of like you're doing now virtually, do so in person. That person may turn into a mentor for you. So at this time, I will stop. Please feel free to drop questions in the chat. If we were on Zoom, I'd say unmute yourself, but I know for our organizers in the background that are on Zoom, they can also feel free to unmute themselves, and we can go into a Q&A. We definitely have 8 to 10 minutes left. I'd love to answer any questions anyone has, but if we knocked it out of the park, I also know that I can just wait here.
Yeah. So while we wait on some people typing their questions in the chat, I have a few questions I wanted to ask you.
Sure.
The first of being about subspecialties. So emergency medicine was your residency, but I guess I can ask 2 questions. First, why do you think did you consider going into a fellowship? And the second being, what fellowships are available?
Great question. So EM fellowships we found don't really change the pathway as a fellowship would for, like, let's say my wife. She did pediatrics, she did a fellowship, she does neonatology. Now she's only going to see babies in the NICU. She's not going to see like a 7-year-old. But in emergency medicine, a lot of the fellowships are for niche areas in emergency medicine, like ultrasound. All right, we all kind of need to know how to use an ultrasound, but if you're the ultrasound guru, you really need to know how to use an ultrasound. There's administration fellowship. There is wilderness fellowship. All right, so you're out in the wilderness as an ER doc. What do you learn? There is toxicology fellowship. So there are different things, but at the end of the day, you don't know who's walking into the ER. So all of us ER docs are pretty just great with being board certified. So I never truly thought of getting a fellowship. I thought my chief year was good enough for my leadership, and that's all I did.
Yeah, that is definitely a great point. Never one that I've thought of. So thank you for adding that.
Mhm.
Another thing is, and I mentioned this at the start, you hold a few leadership positions at your emergency department. What do you think allowed you to get in that type of role?
So one of the beauties about emergency medicine is we actually have a good amount of time. So in a 31-day month, I only work about 12 times. So as you can see, I have 18, 19 open days where I can work administration. Being a chief, I kind of got used to being in some sort of leadership, and I felt it was better to know things early and guide the ship rather than being in a ship that's guided for me. So I really wanted to become medical director. I was glad when I got that role, and I feel like I did a decent job as medical director that I got promoted up to chief of staff. So it's a very big honor. It lets me know that I'm doing good work. And if anyone has the leadership bug, I dare you to try it.
And then one question we have coming from the chat, a student asking about how there might be some patients who kind of hold opinions at a different level depending on who the professional is, right? So a doctor versus a nurse. In that type of case, how do you go about approaching those patients with discrepancies in their opinions?
So like patients may look at a doctor and feel one way, like they are gods, and look at a nurse and think they're just mortals. I guess, is that the question?
Yeah, so they actually give an example here. I'll read it
Okay.
out. So they say that, like, for example, a patient who might dismiss a nurse, right? And you might not be there with that nurse, saying that the nurse is not the doctor, right? They're just dismissing their opinion. But if you were to come over and you were to hear word of that, how do you typically approach those situations?
So I approach the situation first from the standpoint of be nice to those around you. If you want us to take care of you like family, you need to treat us like family. So if you don't want us to be dismissive or aggressive, then you shouldn't be so as well. I am the patient's physician, so I understand wanting to hear from me. But sometimes the nurse is just as qualified to ask a question. So I usually just bring it up and to please treat people how you want it to be treated. That usually corrects most of it. And in the end day, at the end of the day, standing next to your nurse is always better, and having their back is always better in the long run. Because that patient is going to leave and be out of your ER in the next couple of hours. You're going to work a whole shift and multiple more shifts with that nurse. Now, if the nurse was out of line and caused the kerfuffle with the patient, you can speak on that to the nurse. But if the patient's out of line, it's best to correct them soon and early.
And you mentioned a little about kind of how your call schedule looks like. So to tag along with that, one of the students asked, what does your work life schedule, or life balance, I should say, look like? A lot of people think emergency medicine is very hectic. I'm sure it is during the shifts, but overall, in a full week, how would you say that balances out?
So the average ER doc works somewhere between 8 and 12 hours per shift. And my site is 12 hours, and I work about 3 days a week. So for those 3 days, I basically go to work, come to sleep, go to work, come home and sleep. But on my off days, I get to do clerical work. So today I was off doing this Zoom, obviously. I answered a bunch of emails. I made sure to make some phone calls, did some stuff around the family. The plumber came out, and I can stack those days up as I need them. So they usually have about 4 of those during the week. Also, Google Calendar. I have everything on my Google Calendar or whatever calendar you like to use. And as my wife says, if there's no notification, there's no invitation, you don't want me to be there. So start putting little tips and things for yourself along the way, and you get to make sure you get through your day pretty easily. As far as work-life balance, I also make sure that I put in things that I want to do that'll make me happy at least once a month. For me, it's very simple. It's like a couple hours of gaming or playing with friends or going to a game. So I definitely recommend that everyone balances that out into their life. If it's just work, 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 you are going to burn out.
Another question we have is from a student asking, you mentioned how important it is to keep the ER fluid and moving. How does one motivate patients to leave without seeming too pushy?
Most patients want to leave. People don't want to be in the ER. I joke that I'm in the ER because I get paid, and that's how most people feel. So when it's time to leave, just make sure that you reassure them completely. The people who don't want to leave the ER either aren't reassured that you found the answer, have nowhere to go, or have nowhere to get where they need to go to. The first and the last one are pretty easy. You can go and reassure them. You can help with a taxi or ride or anything that's in your neighborhood. For the ones who have nowhere to go, that gets harder. And the best you can do is try to apply resources to the situation. case management to help your homeless people, someone who's abused, they can find shelters, things of that nature. But working and kind of just talking directly to the patient is way easier than avoiding them. Because yes, they'll go hang out in the back of the ER and make a bigger mess of things.
And then you mentioned your wife is also a doctor. Just from a parent's perspective, how does that play a role into how you've raised your children in terms of, the time that you can give them to go to the events that are important for them, just generally raising them up?
So we found that generally raising them up, one, being two physicians did not give us the ultimate parent handbook. We still know as much as any new parent. So you still figure it out as you go. But the bigger thing we've noticed is our time management has to be more stricter. So we have to be home to make them dinner. We have to be home to put them down to sleep. We have to be on a schedule from that standpoint. So we've become very, very rigid in that. The one thing that I think people overthink is like, oh, you're both physicians, you have no time for your kids. Everyone works 9 to 5. My shifts are 12 hours, so there's an extra, 4 hours tacked on that, but that can be factored into travel or before they even wake up. So as long as you keep work at work, and then when you're at home, you spend time with your kids, they don't know any better. They see me in scrubs and they say, hi and bye, daddy, and give me high fives, and that's all I need before a shift.
Yeah, it is the little things.
Yep.
And then one last question, just to wrap up the hour.
Yeah.
Another one from a student asking, how do you approach patients who might be hypochondriac?
Ooh, most hypochondriacs believe that they are great thinkers and that something is wrong with them, and they believe that they are logical. So I always say, try to appeal to their logic. I have a saying I say more times at work than probably some others are, is success is a function of expectations. So you sit down with your hypochondriac and I say, what do you think is going on today? Doc, I think I'm having a heart attack. Well, we have this EKG. It was negative. We got 2 or 3 troponins. They were negative. No sign of heart attack. No one's going to diagnose you with a heart attack. It's not there. All right, what if I have cancer? All right, we did an x-ray of this limb. There's no growth there. If the cancer is early, no one can find it. There's no way you can know about it. Nothing we can do about it. So I try to appeal to their reason and their logic. Sometimes you break through, sometimes you don't. And you just have to say, well, all I can tell you is that you're not going to die in the next 48 hours. I cannot rule out that, you were abducted and had your toe played with, you weren't there. But as long as you tell them the bad stuff isn't there, that's usually what will reassure them and allow them to leave your ER.
Mm-hmm. All right. Well, I think that's going to wrap it up for today's session. I have to thank you, Dr. Anani, for this whole presentation. We love the interactiveness. It's not something that we get to see until usually the Q&A. So it was great to have that. The cases, they were really great, especially as you kind of guided us right through the cases where we decide on which one to tackle first, all the things that you'll see with emergency medicine though. So we really have to thank you. I do have some last reminders though, before we do hop off. So for those who are listening in, if you'd like to earn credit for your attendance today, we have a quiz. And once you pass that quiz, you'll receive a certificate. It's just 10 questions. It's a Google form. I have it in the chat box, the same place that y'all have been typing in your questions. And it's also on our virtual shadowing page. It's also under the video's description. So any 3 of those places, you'll still see the same quiz link. And that quiz will be due at 11:59 p.m. Central Standard Time on this Sunday, June 18th. If you pass that quiz, like I said, you'll receive a certificate. It will be sent via email. So please list one that you're comfortable using. We recommend a personal Gmail or Yahoo email in the quiz. We have a question for that. And if you don't happen to receive it, please do check your spam folder. But if it doesn't happen to be in either, please do shoot us an email. Again, our email is community@hearts4health.org. We're happy to take any questions. And a quick announcement, we do have our application later this week on Friday. That's the deadline for our application to join our team. So if you'd like to hop onto our shadowing sessions here as a session coordinator, or join us to create programs outside of virtual shadowing, like our mentorship programs, our volunteering programs, those programs are local. We have them in person. We also have them virtual. So we've done some pretty unique stuff, some pretty diverse stuff. We've had clinical programs. We've had non-clinical programs. So if you are interested on that side, we also have a role as a project developer. And then we have our graphic designers. Those are the 3 positions we're offering on our application. And if you're interested in joining our team, if you have those skill sets or just generally that interest, we definitely recommend that you apply. That link, the information for it is available on our Instagram page. I believe it was just a recent post sometime 2 weeks ago or so. But like I said, it will be due this Friday at 11:59 p.m. Central Standard Time. So if you're interested, please be sure to get it done by then. We're happy to take any questions you have about that too. And then one last thing is we will have our next shouting session, not this Thursday, but next Monday, June 19th with Dr. Kittleson. She's a cardiologist, a subspecialist in cardiology, actually, in heart failure and transplantation. So we're excited to see her on Monday, same time, 7 p.m. Central. Like I said, if you want to follow us or just stay tuned with what kind of specialties, what kind of speakers we have our Instagram page, we have our email listserv, both great ways to stay tuned with us. But if you'd like to follow Dr. Anani, he has an Instagram page too. Do you want to share your handle?
Sure. Yeah, my Instagram handle is T4. I always have to like make sure I get it correctly. T4D_ Dr. Anani. So I'm gonna double check, make sure I say it correctly. I'll spell it out for everybody. I'm pulling it up so I don't get anything wrong. Yep. T, the number 4, D_ DRANANI. You can follow me there.
Perfect. And I actually also think we have it on our Instagram flyer, the post that we had on Instagram. So if it might be easier, y'all can also check that out when we send out the flyer. But that is all. Again, thank you, Dr. Anani. Let's hear some thank yous in the chat for him for getting this presentation together. I'm sure not only from my perspective, from everyone's perspective, this was such a great presentation to hear from. It's been a while since we had emergency medicine. I think it's been a good couple months now. So very, very nice to see the specialty. But that is all. I hope all of you have a great rest of your week, and we will see you next week on Monday. Take care.
All right. Bye.